After 9 a.m. First on our agenda is our invocation. Miss Donna Bunce has been kind enough to agree to provide the invocation for the meeting today.
All right, should I pray? Lord, I just thank you so much that we can come here today and just have good, healthy discussion about the most precious people of Ottawa County. Lord, just be in this meeting and talk us through those things. Lord, just give extra just gratitude to bring us to this season of Thanksgiving where we can just have an attitude of gratitude to you for all your goodness and your provision and all the things that you do to be the faithful God that you are. Thank you, God, for all of that. In your name alone, amen.
Amen. If you ever go to Compassionate Heart, they call her Miss Donna Bunce. I love you, Miss Donna Bunce.
They do say that.
They do. It's all one word. Yeah, all one sentence. All right. Next on the agenda is the CMHOC mission and vision statement. The mission is Community Mental Health of Ottawa County partners with people with mental illness, intellectual and developmental disabilities, and substance use disorders, and the broader community to improve lives and be the premier mental health agency in Michigan. Our vision is Community Mental Health of Ottawa County strives to enhance the quality of life for all residents. So next on the agenda is public comment. If you have a public comment, please feel free to step to the dais here. You have 3 minutes to speak and cite kind of where you vote and your name. Good morning.
Good morning. Barbara Lee Van Horsen, City of Grand Haven, and the Momentum Center. I want to tell you about one of our previous members. She wrote a letter shortly after joining, telling us that it saved her life to find a place where she found people who cared, whether she chose life or death. But that wasn't the end of her story. She had a major depressive disorder, and more than once we intervened in her actual suicide attempts and celebrated with her each time she returned to us. But as time went on, her attempts became more frequent and her quality of life suffered. We became alarmed by her living conditions and the lack of family support she was receiving. We came to realize that her life was endangered and made the difficult decision to report the situation to Adult Protective Services. That was about a year ago. Since then, we've thought about her a lot. We've wondered how things turned out and if she was doing well. Well, 2 days ago, I walked into a waiting room to see her sitting there. Upon seeing me, she immediately leapt up and we embraced for a very long time. She looks amazing. Her face is relaxed and her eyes shine. She explained to me that she's living at an AFC home now in Muskegon and that she's doing well. And I couldn't be more proud of the fact that the Momentum Center did that my staff did that my volunteers did that. They surrounded somebody who was hurting with love and genuine care and concern. The words social recreational may sound trivial and frivolous, but they are about creating meaningful relationships and providing life-saving connection to other people. My only lament is that we don't have a location in Muskegon for her to join. We do, however, have locations in Grand Haven and Holland, and I need to ask your help for our Holland program. We need to move out of our current location by April 1st, and we've not been able to find a new location for our program. Cost is a factor. There are places available, but that we cannot begin to afford. And as you know, we've had to cut $40,000 from our budget this year because of the reduction in our millage health, our mental health millage grant funding. So please keep your eyes open and let us know if you find any space that could accommodate a small office and a large enough member space for crafts, activities, and the powerful act of building relationships. Because if we all work together, we'll keep gaining momentum.
Thank you. Good morning.
Dave Barnowski, Sheldon Township, and I'm a veteran who attended by a public meeting in the United States of America that begins with an invocation and not the Pledge of Allegiance.
We can always add the pledge. Know why we haven't had it. Thank you. Is there anybody else who would like to speak? Seeing none, we will move on to the consent items. The suggested motion is to approve the consent following items. The agenda for November 22nd, 2024 CMH Board of Directors meeting, and then the minutes for the October 25th, 2024 CMHOC Board of Directors meeting. Do I have a motion?
Second.
All right, motion and second. Any discussion? None. All those in favor of approving the consent items, say aye. And opposed, same sign. Motion passes. Moving on to action item number 6, or item number 6 on our agenda is the Executive Director's Report. Attachment A with Dr. Michael Brashears.
Good morning, everybody. I've been told I only have till 11, so I'll talk fast.
I didn't tell you that.
Normally I have a,
We have until 11.
That's right,
not
that's
you.
right, well, you have till 11, right? I can leave at any time. That's right.
There you go.
Usually I have a written director's report. Today I'm doing it verbally because I have so many other attachments and agenda items. They're really the main focus. So I will make sure I do that. I want to apologize to the board, by the way, of all of the late attachments coming to you this week and LRE contracts coming to you this week via mail. If you tried to actually read all the material before today, I think you'd be up till 4 a.m. trying to do it. There was a lot of issues we were resolving with the regional entity in terms of the finalization of the contract to get approval from you today, for me to sign today. And that literally went up until the last minute, until Wednesday. Dave Purnham was at the LRE board meeting, knows exactly what I'm talking about. But we'll do a better job in the future of getting attachments out to you quicker for your review. There's a lot of information that was sent out, and I want to make sure you have the adequate time to review it. So a couple of things that are not covered under the presentation agenda items is, hey, I had the pleasure of completing our 5th Did You Know Executive Director Educational Series last Friday. The emphasis was on grant funding. We had a very good turnout of both providers and citizens. And we're in the process of making sure those get turned into recordings. There's a couple of things I need to do. So the whole series that we've done on funding sources, we covered Medicaid, we covered general fund, we covered CCBHC, we covered millage, we covered grants, are going to be reduced into abbreviated kind of video series that any new board member, any citizen, any person can see and review. And so we're hoping to having that done by the 1st of the year. So that series will be on our website. People will be able to see it, and it'll be a board resource. I got some feedback from the community that one of the aspects that they liked, one of the takeaways they had from our last presentation is that you lose your Medicaid when you go into the jail, and that we utilize a lot of our grant funding to help provide services in the jail. And without the grant funding, that's very difficult to do. And so that was one of the major takeaways that people went through. I did send you a copy of the materials of that meeting, the PowerPoint presentation. And so at your leisure, if you go through and you have questions, ask me on that. We're going to be beginning a new series. It will start in December. If I can pick a date that doesn't conflict with a new board meeting date or another Friday. If not, we'll do it in January. I'm starting a series on access to CMH services. It'll be a 3-part series of how do you get into CMH? What are the actual requirements? Who we actually prioritize to serve? Who don't we serve? So it will begin a series of community dialogues on access to CMH services. As this board remembers, when I first came on as an interim, there was a concern about understanding the funding sources, and we did education on that. Who gets into access service, and then following that is how do we determine amount, scope, and duration of the services that are approved? Why are there differences in some approvals, like CLS for some people, up or down or whatever? So we're putting together a series that I think that could be played at any time, regardless of who's doing it or what year it is, because unless the standards change, it's a good educational piece. So look for announcements on that.
Michael, or
Mhm.
Dr. Bertiers, I just want to thank you for doing that because of all the parents I talk to, that is probably the number one, I hate to say this, complaint
Sure.
of not understanding any of the access or denied. So thank you for doing a specific attention to that.
It'd be a three-part series
Yep.
broken up in hopefully digestible pieces. There's a lot of regulations in it.
Yeah, thank you.
But yes, we will do that. Also in your packet is a couple of handouts that the Board Association sent to us. They're just for information only, and then one is entitled Michigan Public Mental Health System, Your Local Safety Net. It's like this infograph thing. And they actually had sent an email. Remember, we had Alan Bolter from the Board Association come to this board. He's the second in charge there. He said, hey, would you like us to come back to the CMH board and explain some of the other upcoming things? They said, yes. So he'll come back sometime either in December or January to go over some of the materials that are in there. Really, the advocacy aspect of the Board Association is really what we could utilize as a board. And they're really good at putting together kind of these infographics and descriptions of key issues. You also have a list of state legislators and their contact information in your packet. That will be handy because I'm about to embark in a pretty aggressive Medicaid funding initiative to raise more Medicaid funds for our county. It shouldn't matter where you live, Medicaid funding equity now. Every CMH board, in my opinion, should have the same amount of Medicaid per person. The standards are exactly the same. I know there's alleged regional differences, but a person on Medicaid is a person on Medicaid. And the provider network and all of us all deserve consistent Medicaid rates across the state. So it's in one of my other presentations, but you should know that I'm putting together an advocacy plan to increase Medicaid funding in an equal way throughout the state. I am not saying that the regional entities not giving us enough Medicaid. I think the whole system is underfunded, and I believe that it doesn't have equity. Mr. Byrd and others remember we had to do this with the general fund dollars when I was here the last time. Same campaign, same idea. Shouldn't matter where you live, funding equity now. So I'll be calling for families, providers, representatives, county administrative staff to help me in this regard to ensure that all CMHs, especially us, get the adequate amount of Medicaid funding to meet our obligations. So I'll be putting together an advocacy plan related to that. That will be rolled out in December and January. Nothing happens till after Christmas, but I'll start working on that plan now for your consideration. There were several Lakeshore Regional Entity meetings over this month focusing on the contract between us and the Lakeshore Regional Entity. And just a reminder, the Lakeshore Regional Entity is the body that we're a part of, the organization that actually gives us Medicaid, the Medicaid, and they help monitor how we spend it and the regulations. They're that, if you remember, it goes the federal government, the state, which is MDHHS, then to the regional entities, there's 10 in the state, Lakeshore being ours, then the money comes to the CMH. Yes, there's that many layers before the money reaches the folks. So, we had a lot of meetings related to the contract. I'll be seeking approval from you to sign that contract today, and we'll be discussing it later in the agenda. Other than that, in terms of my director's report, the rest of the information I intended to cover are actual items on the agenda. So I'll just defer to them at this point. Any questions so far, I guess?
One question for you, Michael. Losing Medicaid when you go, if you're incarcerated, we still provide mental health services in the jail system.
Yeah.
Do we do that for SUD as well?
Yeah, in the jail. Yes, and we have a specific grant that actually we got to do that. Medication assistance treatment program in the jail. And there's a lot of coordination of when people are leaving jail in terms of re-entering back into the community. What's tough about it is that when they leave, they have to reapply for their Medicaid. And it can take weeks. So you could have somebody that literally was a consumer of ours or a client of ours on Medicaid, on a program, have a life issue, go into the jail, lose their Medicaid, come out of the jail, right? Have to reapply. You can't just realign all the services instantly. And it's a major flaw in the community and public mental health system. And when our system went to having our funding primarily as Medicaid, as our primary funding source, this created the problem. You go back 30 years ago when most of this was funded, well, 40 years ago, with state general fund, you could just transfer the stuff right into the jail. Now, the jail is also obligated to have healthcare services as part of their stuff, but it's often not robust enough on the mental health side. And so we partner with the jail for many programs using our grants and some millage funding to make sure that's happening. There is talk in the state to work with the federal government of allowing Medicaid to stay in place when they're in the jail, and we hope that happens pretty quickly.
It's almost like they think incarceration is cure. you
Yeah,
know?
well, You know, to me, when you're in jail, there hasn't been a verdict yet. And I believe you're innocent until proven guilty, so you shouldn't lose your health care. And if you're guilty, go into prison and they have mental health care, right? So yes, I don't know if people think it's the cure, but really it's just not well thought out. And the reality is because Medicaid is a health plan type service. So, and you know, that's the primary issue with that. But I'm glad we have our grants and our use of millage to help in this regard.
I'm going to ask about your next series here, the access to CMH services, amount, scope, and duration. Is this something you foresee in the future, maybe putting out and making available publicly then?
Oh, yes.
too? Yeah.
Yeah, and the
There's
public's involved.
direct-
They're able to go to the presentations now. In fact, the last one I had mostly public.
Wonderful.
I have my 4 or 5 public representatives that come to all of them, and it's nice because we end up having a robust discussion about things. And a couple of them here today. And what's good is I answer like a whole bunch of questions at once. And so the reason why we're not recording the actual sessions is because some of my public take me down a different trail of questions, and I don't want that on tape. You know, it's like we're talking about grants, we end up talking about something else for 5 minutes. But it's a chance for me to get to know folks and to educate. I've been taking the lead. I haven't asked CMH staff to come in and do the presentations, even though they helped me prepare for it. And it's been a way for me to engage with the community. Yeah. So we've had 5 of them already. I can't believe, you know, I've only been in here about 100 days. We've done 5 of these things. So,
Thank you for that.
yep.
Next up on the agenda is a presentation for the 2024 budget deficit and 2025 funding levels. And again, Dr. Michael Bertiers is up.
So you have a handout, and we'll put it on the screen as well. And the document is called FY 2024-2025 Medicaid Deficit Reduction Plan Update to You. Okay. And this will be posted in the general packet that the public can download. So I'm going to go through this as well. I completed it, the final draft of this morning. That's why it wasn't sent out. So as you know, I sent out earlier this month in November that when we were closing our books for the fiscal year 2024 that ended on 9/30, when we were closing our books, we had a dramatic increase in our anticipated expenditures for Medicaid. We're still figuring out the exact number for fiscal year 24. It can range from 4.2 to 5.9 million. There's a lot of variance we're looking at. And that was an unanticipated increase of our Medicaid uses for that year. Until we closed the books on the quarter, as you know, we were not projecting that to you as a board. So the several months before we were coming in, there wasn't us saying to you, hey, if all things being equal, we're going to end up being with a Medicaid deficit. So over the last several weeks, we've been doing a pretty deep dive on how can we do a better job anticipating a deficit. It's led to a 7 to 11 changes I know fiscal services is going to do to help us track it better. So I just want to walk through this because it has implications for the 2025 budget that we're currently in, that if some of the trends that we see that are continuing, which I'll go over in a moment, in the fourth quarter or last year, I should say, continue, then we're anticipating at least a $3 million gap to fill now, if not more. And so what I want to do is briefly, as best I can, walk through my initial impressions after 2 weeks of understanding this, the actions we have taken thus far, and then the immediate recommendations for immediate actions we need to take immediately, and get your input on it. So as the document illustrates, that it's clear to us that in 2024, last fiscal year, because I know it's calendar year, it's different, we saw a dramatic increase in specialized residential placements. In fact, we had 31 new placements. And the year before, it was pretty similar as well. When looking back at some of the data, we averaged around 20 to 22, some years even less. Each residential placement can cost between $70,000 and $100,000, just depending on where they are or more. So because we weren't necessarily aligning our utilization for how many people were going in to forecasted expenditures, only when all of the billing and stuff started really hitting the books in the middle of last year into the fourth quarter did we notice this. This is an issue of us not having a solid utilization management program of looking at use of specialized residential, increased use of specialized residential, and the impact to the budget. And you'll see that we've been in a robust process of fixing that immediately. So the other thing that we notice is that our community living support authorizations across the board had a dramatic increase from one year to another, close to $1 million in that area. And looking at our CLS expenditures, it's clear that we need a more stringent and predictable utilization management system for that, meaning there are huge variations in the amount, scope, and duration of what's authorized for CLS. And, someone that's in a self-determined program, how many hours are we allowing? Somebody that's not, group CLS, individual CLS. And the rates are all over the map too, in terms of the logic model of what is our rate scale for community living supports. You'll see in my immediate steps, we're looking into that, and we're going to be doing a deeper dive in December and in January to fix it. And that's one of the things that's been confusing to some families out there. Why does family A get this amount of CLS and family B gets this amount of CLS? What is the medical determination criteria we're using, and how are we making those decisions? So we have to dramatically strengthen that area of the business. In fact, most of our utilization management tracking. But it's specialized residential, CLS authorizations. We also seen an increase of $1.5 million in unbudgeted autism services. Autism is our fastest growing population that we have. And you'll be getting more of the access data from last year, next board meeting, like how many people we served, which population group, what's the percentage of the increase, and is there a budget to support it? If you remember, I've often said to the board that our budget is our budget. We get the same amount of money from the Medicaid side, regardless of the amount of people we serve. I wish there was a one-to-one correlation with I serve a person, I get money back in, or fee for service, because if you have a huge increase in a certain population, we would get more revenue. This board does not get more revenue in the Medicaid fund for any increases in access at all. So if you have a flat to decreasing Medicaid budget, you're expected to serve your current folks and any new people within that budget. And so that's why I was mentioning earlier that we have to do a pretty aggressive Medicaid funding equity campaign, because it's my belief, regardless of us tightening up our utilization management and doing other control features we do, that we really need more revenue as well, especially if we want to increase rates for providers on the Medicaid side the way we need to. So they're all related. There's also been some kind of delays in the execution of contracts that we were able to clear up when our routing process, when they're signed, because the delay, even though you may not be booking the expenditure early, can hit the books later. So we had that, and we looked at several processes with that, delay in our billing processes. One of the things that's going to help us significantly is this is a board, if you might remember, we're switching to a new EMR record or a new electronic medical record system that will have all of the billing platforms and other things that we really need, like every other CMH, to have. We believe that's going to help us with forecasting, checking secondary and third-party insurances, and some other business practices that right now, unfortunately, with our current system, the fiscal services staff sometimes has to double data entry, sometimes triple data entry, manually select insurance coverages. It's right out of 1986. So one of the fixes that we already have in place for this is to get a more efficient system to help us with our CCBHC funding streams and requirements and the like. And we will have that, we're slated to have that system fully implemented, is it June or July? I always forget. June 1, okay? Which was expedited. They usually take a long time, but we know the person that's doing it, and they said, all right, we see the need. So June, we'll have it in. That should have a much more predictive analytics for us that will be in line, by the way, with every other CMH in the state that uses the same program and with our region. Right now, we're an outlier. We have a system that when we first put it in was the bells and whistles and everybody loved it. No one else uses it, so it's kind of atrophied. And this will really help us with our budget monitoring, forecasting, and various other things. There also was an increase in inpatient psychiatric hospitalizations the last 2 months. We were almost averaging a admission or 2 admissions a day. Every one admission could have 7 to 10 days at $1,000 a day, so it could be $70,000 or more for every admission that we have that goes over what we were budgeted for. If you remember, in the budgeting process, we added 3% as the number of the increase to all of it. All of the above services, I said, went far above that 3%. And so if we were tracking it a little bit differently, we might have been able to predict that impact sooner. And that's what we're going to fix immediately. But we have to do a root cause analysis on why the increase in psychiatric hospitalization, increase in specialized residential, variance in CLS expenditures. And I've started those processes over the last 2 weeks in an aggressive form.
Michael, if
Yeah.
I could interrupt here. Utilization management is an important aspect of trying to be economically reasonable in delivery of services. The dilemma is not all consumers are created equally.
Correct.
Every MI consumer may require different levels of support, and unfortunately on the medical side, Humana or Blue Cross is going to say, well, we'll give you 7 psychiatric appointments. That's it, period, you're done. We can't just cavalierly put a cap on services. We have to look at the individual.
Yeah.
And I'm reminded of a famous quote from, having a senior moment here, Mark Twain. And he said, I'm reminded of my friend who drowned crossing a stream, the average depth of which was 3 feet.
Mhm.
So when we're dealing with utilization management, we can't just deal with averages. We have to look at the individual circumstances and needs. And the crux of that, as you're well aware, and as the contract with the LRE will point out, we have a mandate. We have to provide services that are appropriate to the needs of the individual. And we cannot arbitrarily reduce services. So we're caught in the
Yes.
vice here. And this is, I know you're focused on this and in terms of taking our pitch to the legislature to say, you guys have to give us the resources to make us whole for the services that we're required to deliver.
Yeah, there's a difference between a benefit and an entitlement. So if it's just a benefit, then the person that offers the benefit can restrict the amount, scope, and duration and say you get 10 visits. If it's an entitlement, you cannot do that. You have to authorize the amount of service that's medically necessary for a person receiving services. This is the crux of the argument. So my approach to this is say, have the best utilization management, meaning look at equity. How are you authorizing it? What are the rules and definition of how much based on medical necessity criteria we're using? Getting really good at that so that we can explain the differences in individuals, not restrict the differences. You cannot just say, starting tomorrow, you only authorize 10 CLS units because we're broke. In fact, you cannot limit the amount, scope, and duration of any services based on finances. It says it explicitly in the Medicaid provider manual. We can't do that. So the game is, what are we authorizing? How much money do we get? And can we, as a CMH, ethically explain the differences among what we've authorized with a logic model? And that's what we got to do. And we got to get better at it. And we got to track it. Because you are right. I can't say to somebody that needs specialized residential, you can't have it. It's a level of care. So it's not about denying entry into the specialized residential world. Oh, that's how you're going to UM. It's understanding when we're making those decisions and how we have an adequate network and making sure there's funding to allow it. I met with the staff for several hours yesterday. We were talking about specialized residential, and we're looking at the potential of we could have up to 50 people in the next 2 years that will need it. And there are several variables associated with specialized residential and the impact to it that at a later date, I'm going to provide as a comprehensive dialogue on. But just to give you a hint, there is a housing crisis, as we know, in the whole state, especially for folks with disabilities or different abilities, I should say. You think it's tough getting an apartment for a person without different ability? Try getting one with. And so that has had an impact on the development of general AFCs or having places for people to live with supports coming to them and is leading to an increase in specialized residential care. And I intend to flush that out and have several public dialogues related to that because that's a huge variable. So it's not about restricting care. It's about being able to defend how we make determinations on care and making sure it's equitable. And that's the approach we're going to take. So you can read through this, but there were several notification things I did immediately. I found this out. I just got back from my daughter's wedding, first email, like, oh, we have this. So I started a series of notifications. We've notified, obviously, the Lakeshore Regional Entity. They're well aware, and we're working collaboratively with them to do an analysis. And they've been wonderful partners once they found this out. They weren't like, oh my goodness, the sky's falling. Their approach has been, we're going to help. We're going to figure out how to deal with this and look at all the variables that you're presenting. We told the Lakeshore Regional Entity that we are going to be 100% transparent with all of our books, processes, procedures, and we welcome their assistance. And they will offer that. And we're working out a plan on how to do that. Maybe we're missing something that they're seeing. Maybe there's issues that they can help us with. So that was one of the first notifications. Then you were next. I've also informed the county administrator and county leadership. I've also informed the provider network of this issue and all employees. And it's tough because when you let employees know that there's a deficit or providers, the first thing naturally they're going to say is, what does this mean for me? So what I've been saying is, listen, first of all, in the 24 years I've been in the system, there's only been one time I've ever seen a budget come in actual of what you projected. It could be up, it could be down. So this isn't necessarily abnormal. What makes this different is we didn't see it coming as quickly as we could. And so we're fixing that. And this allows us to have an opportunity to strengthen all of these things. So I wanted staff to know, because what I don't want them to do is listen to our board meeting and here we have a deficit. and no one's at least tried to communicate with them. So I first did a series of notifications.
I just want to bring up though, too, this is not unique to Ottawa County having this Medicaid
Correct.
shortfall, correct?
Yes, our Network 180 has a significant shortfall as well, and other CMHs in our region throughout the state have significant deficits as well.
And so you have a professional group that you meet with other executive directors, and are they planning on also advocating for increases in Medicaid?
Through the Board
spend-
Association, yep, through
Okay.
the CMH Board Association, we've pulled together a group, and yes.
Because it's a multifaceted problem, one being, kind of feels like root cause might be Medicaid reimbursement though, too, but then better projections. Although, would we have been able to project out that there would have been 31 new residential, people seeking new residential services?
We might not have been able to project it from the prior year, but we could have, and we will do a better job knowing on a monthly basis. One of the immediate steps I'm doing is I am improving all specialized residential placements personally until we have a process that can adequately track it in the way that's satisfactory to solve the issue. And we're getting close.
So being able to ask for resources maybe earlier rather than at end of year.
Yeah,
is what
or
you're
project
thinking?
out.
Yes.
Yeah.
And then the other thing about utilization review, because I know that's when you work, all of us have insurance, of some
Mhm.
measure, and it's always terrifying when you hear URs coming in to kind of tell you what you can get and what you can't get. In these circumstances, though, you're going to build a structure is how I hear it.
Correct.
And so, but yet individualize after having a structure. So it's just easier to understand, not just for the consumer and family,
Right.
but also for the team that's caring for them.
Correct. Within the program level, we have to do a better job communicating and generating reports to fiscal services to help project. So they're doing the best they can with the resources they have. And so when this first came out, Amy was like, gee, how did we miss this? Well, it wasn't her that missed it. It was our system that didn't have the appropriate data getting to the right people to help project it. And so we have to rebuild that infrastructure quickly, and we are, to ensure that our utilization, what we've authorized, is figured into potential expenditures. As a board this firsthand. One of the first things I did and changes on the contract sheets. Remember, we would just have a range, right? From 0 to whatever. I'm like, well, how much money are we actually spending? Right? So unless we're really capturing that in terms of projections, we're just dealing with ranges. Worst case, best case scenario. So if you have a worst case scenario, like, oh, if you have a best case scenario, go, great, we have $1 million to send back, right? I want more of a detailed process to look at it, and we're working on that now. I will say, when you go through this document, because I'm jumping around, there are some immediate actions I've already taken, which that I've listed. We reviewed the budget forecasting and budget management processes, and fiscal services already identified 7 process changes they're going to look at immediately to strengthen this. And once we get those worked out, you'll see what they are. Okay. We've reviewed the specialized residential services utilization management process, and then I'm effectively taking control of that. You'll see later in the presentation on organizational changes, I'm now directly supervising the residential supervisor that manages all of our residential authorizations throughout our system. So that's the change I made immediately. We're reviewing our CLS process, and we have an effective date to be done by 12/30 on recommendations and changes there. We're reviewing autism services utilization. It's the fastest growing population, but does the revenue match the growth? Working with the region and other folks to look at that. We're reviewing inpatient hospitalization trends. That will be done by 12/30. On the next one is a little bit more nuanced, so I want to spend a couple of minutes on that. So we're reviewing the county cost allocations to us as a CMH. You might remember that what happens is that the county has an allocation process of county administration and county central services that they give to each department to fund. So we have a cost allocation. CMH is the only department that has to come up with 100% of the revenue to cover that cost allocation. So what does that mean? There are other departments that have fees and stuff like the court systems and things like that that will pay for some of the cost allocations of county services in there. But we're the only department that we point, because I am we, to the Medicaid fund and say, you shall pay all negotiated raises, all negotiated changes in healthcare, all increases in county expenditures get allocated to us by either FTE size or whatever the methodology is. We are asked as a department to fund 100% of all of those charges with the Medicaid fund. So when you look at a difference between 23 and 24, and I didn't put all of the spreadsheet here, sheet here, because there's like some went down. There's about a $3 million increase to us as a department from last year to this year. And the bulk of that is, I listed in the table that's listed here. So there's a $490,000 increase in just overall county administration costs. That could be increase in legal fees, whatever it could be, many different things that are allocated per department. And our allocation for this year went up by almost $500,000. There's been an increase in IT, not the IT that we're doing, but just IT costs for the entire county. Because remember, we have our own IT budget as well. That's how we're funding the EMR and things like that. That went up, our allocation went up by $300,000. We're now unionized, and there was a negotiated increase for staff that are in the union by 4%. And that could, and another fringes and benefit increases of 1.8. And then our health insurance, this happens everywhere. You talk to our providers, they're getting buried as well. Went up significantly in terms of costs, and our allocation is this. So when you look at a projected $4 to $5 million deficit in Medicaid, I have to, as the mental health code officer to manage the Medicaid budget, look at all expenditures to reduce before I deal with any type of Medicaid service reduction, which you can't do. So what do you do when you have a Medicaid deficit? Okay, well, you have to find ways to cost cut because you can't cut services. I can't say we no longer have an ACT team. We no longer have specialized residential. Don't have it. We signed a contract that said within that money, we're going to do it. So I have met with the county administrator. I've met with HR, and I'm letting this board know that the mental health fund does not have the budget to fund the negotiated increases for the staff. Now, I'm not saying they shouldn't get it. What I'm saying is the mental health fund does not have the budget. The Medicaid fund does not have the budget to cover that. And I'm asking the county to look at other funding streams to cover that increase. Now, that has never happened in the history of our relationship as a county department, where the CMH department has said, listen, county, you're going to have to pick up this cost with a different funding source for your department. Why? Because we didn't negotiate the contract. I have no authority to agree to the limits of this contract. These are county employees, and we're a county department. So what I'm letting the board know is I'm going to formally ask and send a letter stating that our Medicaid funding source does not have the budget to fund the negotiated increases, and please consider other funding sources. Contingency fund at the at the county level, county GF. I want the employees of CMH to hear this. I'm not saying eliminate the raise. I'm saying the Medicaid fund cannot pay for the raise. And that is a fundamental difference that people need to hear. If I was a standalone CMH, not a county department, I'd have to look at all kinds of ways, including asking the staff to not take a raise to deal with this deficit, unless the revenue increase, and we do that. I don't even have that ability. So as your CEO, executive director, I don't even have the ability to say, don't give the employees a raise. But if I had the ability, I would be looking at that unless revenue went up to help solve this, because I'm not recommending reduction in provider rates or any other service that's connected to Medicaid. Some of our providers have not had an increase in 5 years. You're going to see later today in this meeting, I'm authorizing $1.6 million of millage to keep our residential system afloat because I don't have the Medicaid to increase the rates yet. So I can't ask providers to take a decrease in their Medicaid rates when they haven't gotten an increase in most areas for almost a half a decade. So I'm left with this strategy to see if it's even feasible to deal with some of our Medicaid deficit. And you can tell I'm not sugarcoating it. It's never been asked before as a department. If we are indeed a county department, then the county has to share the risk and negotiated contracts with county employees. It cannot be on the back of Medicaid recipients alone. It cannot. So I'm going to be making this request, and I would encourage if I could get the support of the board for that request, unless you think it's ill-advised for me to make this request that the county consider, not saying they have the money, but consider using a different funding source to pay for these cost increases this fiscal year. And if Medicaid goes up and we're able to solve some of our trends, the next year we can kind of go back to the way it was. Because if I was standalone, I'd have to use all the mental health funds to pay for the things, but I would have a lot more control of the fringes and benefits of the employees. Right now, I have no control of any of them, besides just my opinion. Now, let's be clear. When the county was negotiating this contract, we had projected there would be enough money in the Medicaid budget to cover the increase. So the negotiations were done in good faith, looking at the traditional way we did it as a county. But when that changes, I have to ask for a change in which fund pays for it. If not, then we're always paying ourselves first and decreasing the amount of revenue for others that provide services second. So that's probably the most controversial part of my immediate steps, is I intend to write a letter formally saying that the Medicaid fund does not have the ability to fund the staff increases or the county allocation of costs. And can there be relief? If the answer is no, I will do my job and manage the best I can. But in my opinion, it has to be asked. So I'd like some feedback on what you're hearing me say from the board before I send the letter that will be the shot heard around the world.
I'll give you some feedback. By all means, I think that's a reasonable approach. And as you recall from some time ago, we had discussions about the fact that we are renting facilities from the county, buildings that are fully amortized, and yet we're still paying rent on them. And it would not be unreasonable to request either a reduction in rent or an elimination of rent, since the buildings are fully paid for.
Yeah, and so technically, county cannot charge rent, so we're paying facility cost.
Administrative costs, yeah.
So what's put into that is the cost of maintenance and things like that. But that was a decision, Tom, and you were around when this happened, when all of the CMHers were moving from county departments to authorities. They had to reconcile that issue because most of the CMHs were in county buildings, and they could not charge them rent as soon as they became an authority or separate from the county. Only the facility costs, because it's already paid for or amortized. And so really, it's the break on facility cost and maintenance and things like that, or even just the increase of it. But you are correct that it's actually now statute that they can't charge us rent, only facility costs. Yeah.
I know we have several commissioners here. What kind of shape is the county general fund in?
General fund, I think, is secure. And we always have a contingency fund as well. I know Dr. Brashears has had a conversation with Karen at Fiscal Services.
Mhm.
So availability would, I would probably defer to Karen, but you have to have a contingency fund for things that are unpredicted, and just like this particular scenario. The union contract, you were just interim even
Yeah.
discussions had been going on for quite some time, actually
Right.
for almost 2 years. So not necessarily a part of that. When you and I spoke too, it's projections, right? Not
Right.
having it be hit on your last quarter. You had projected that we would have in the negotiations funds for the increases. But as it turns out, due to 31 placements as well as increases in CLS, I mean, things that were unforeseen. Yeah, that's the word contingency feels like it's appropriate kind of application here. I don't know about the other commissioners, what their thoughts are.
No, yeah, I'm with you 100%. I believe there is enough money in the contingency fund. We
Yeah.
just discussed, I mean, we just went through that like a couple of months ago. And so it seems to be a very reasonable ask to make, because as you pointed out, it is essentially and probably will be a one-time, and that's what that fund's for. So I don't see that as being a lot of hang up with that.
And if we are mandated by law to provide services, it doesn't feel, the state should fund that. And I know it's hard to predict,
Sure.
but that should be funded for everybody, not just Ottawa County.
Sure.
Yeah.
So,
You were talking about millage.
Mhm.
We didn't know if there was gonna be enough. But like, I don't know how millage is, like, how they get their money. Is it like donations or?
It's
is it
based on taxes, believe it or not.
taxes?
Mhm.
Okay. So is there a way that there is like an extra fund for getting past?
Yeah, we can look at the use of millage to help us in this situation for sure. In fact, what I argue, we already are. You'll be approving contracts today to use millage to help stabilize residential services that, in my opinion, over time have to be stabilized with a dramatic increase in rates in Medicaid. So it's this battle, and I wish I would have been here a year and a half, and this was happening a year and a half, because it would be much further down the line on fighting that issue. But yes, Ms. Wick, you are correct that millage is a tool that we can use to assist us to ensure that services remain in place. And that's done by tax. And it's up for another vote by the people coming up next year. And so if we didn't have that millage, I would tell you what, there'd be a lot of different type of discussions happening right now. But I will tell you, just because I know we have a long agenda, the approach I'm using is to stabilize internal controls, advocate for more revenue, and then really ask the question, to what degree are we a county department? Because if there's no relief from the county, I'm going to argue as your executive director, CEO, I'm using that because I'm proposing a title change in a minute, to say, well, all right, then I guess we're just a funding source for the county to operate the CMH system. So I'm hoping that we get some relief. If not, as your executive director, we will solve this issue. And we will have high-quality services, and we will march forward. But I think it's a reasonable ask, and I appreciate the initial feedback to go ahead. There isn't anybody saying, don't send the letter, I'm hearing.
No. And the LRE is going to assist as well, but you're doing it more as a loan rather than?
Yeah, so what happens is, for last year's stuff, there's the internal service fund, like the rainy day fund, that we have access to pay for our over expenditures. The key is, do we have to pay that back?
Right.
If we have to pay it back, because we're borrowing it to cover last year's expenditures, then it decreases the amount of revenue we get in Medicaid moving forward until that amount's paid back. So we're waiting for the books to clear and a strategy to look at how do we fund the over expenditures. But that's the whole reason why we have the rainy day fund or the internal service fund at the region, to deal with unanticipated increase in expenditures from the year. The thing is if everybody does that, you end up with $0 in it within a year. Network 180 is projecting a $19 million deficit. If they use that 2 years in a row, the whole fund's gone. So I'm looking for robust controls to limit the impact so we don't have to borrow as much from the LRE, because you have to pay it back one way or another. You can't just go, it's not free money.
Well, and I respect the fact that you are putting controls in place as
Yeah.
well. Even the metrics that you showed us at HHS, I
Yeah.
think will help you with the predicting or projecting what's kind of coming up in the future and whether or not you have the revenue in order to cover it as well. So are you planning on like and I can't remember if it's in this packet or not, but with those metrics meeting or do you meet as a team?
Yeah.
Forgive me for not knowing, and I
Yeah.
don't mean to imply.
So, we're talking about is really
Hospital-
looking at our
Hospitalizations.
kind of,
and,
yes, so
and placements.
developing those measures for each of those areas in terms of, the percentage of growth, anticipated growth. It's forecasting who we're currently serving might need the service. And that's not as easy as you think. This has got to be done at the person-centered planning level. And so developing metrics and reports to help us predict. So literally, I was asking the specialized residential, we had a meeting with all of the supervisors and saying, how many are we projecting for next year? And they're like, well, if these events happen, people can't take care of their loved ones anymore that we're aware of, or whatever it is, we could have up to 35 more placements. Well, that's way above a 3%. So it's a systemic issue that's hitting all of the CMHs that have to be addressed systemically throughout the region and the state. And I've actually already called for kind of an independent study to look at the characteristics of these people to say, are they funded by the state appropriately? If the state knows that on average 20% of clients in the DD population are going to be in residential, does that go into the rates? And the answer right now is no, it does not.
See, yeah, and following
So-
year over, because you're doing a year over year
Yeah.
budget increase, assuming a 3%, but are we following aging trends?
Right. 3% was
to
just
see.
something we used as a tool because we don't know. So we have to get better at knowing. So I'd be able to tell the region, gee, based on our population, we look like we have a 9% increase in this area, 10% increase in this area. And they would be able to look at that and say, well, do you have the controls to prevent people getting into that? If there are ways to do that. If not, how do we work together with the revenue throughout the region and the state to deal with that? So it's also getting all the CMHs in our region on the same page with how we report key indicators. And the key indicators we look at don't necessarily include the three, well, one of them is, the two out of the three that we're talking about. We're not looking at CLS expenditures or specialized residential placement rates within the region. That is something that has to be corrected immediately.
It's like the state should be providing some of that for you though as well, even predicting their budget.
This is what the
the
state says. Here's your money, manage it. That's it. This is what you get,
Right.
manage it. If you can't manage it, we'll get somebody else to manage it. Okay. I'm being blunt.
Yeah.
It's a lot more complicated and they do care, but we have to give them the information.
And be accountable for every dollar you spend.
That's right.
Yeah.
Yeah. So to conclude this part of my presentation, you'll see a list of immediate actions I'm taking, the notifications I have, and I will be providing regular updates to the board, the staff, to providers on where we were at with that. You'll end up having a more comprehensive kind of project plan with some deliverables for each of these items. I had to dive deeply because I only knew about the issue for 2 weeks, quickly, and react quickly to these. And I will tell you, I've had 100% cooperation with fiscal services within CMH, CMH staff, leadership, the region. There has been no finger pointing, just solutions. And so I am proud to say that makes this a lot easier to deal with. Even at the county level, I have not received like, we can't do that. It's like, let's look at it. Let's examine it. So that is refreshing, but we have to act quickly because I don't want to be here in 3 months going, it's $9 million.
We can't not deliver the services.
Yeah.
Yep.
So the next one I have, if I may move on, unless there's any further questions. Did that cover it adequately, what we're in, how I'm going to deal with it? Okay. So one of the things I'm doing is we've already got approval from HR and various departments to change the titles of some of our positions and some organizational changes within, Ottawa CMH. I've been there, 4 months as the permanent director. And one of the things I want to do is to align all the titles of the positions to every other CMH, including county department CMHs in the state. We are the only ones that have a unique set of titles. So any single time we go anywhere, I send Anna somewhere, Anna's position everywhere else is the COO, Chief Operating Officer. She has to say I'm the Deputy Director, and they kind of know what that is. And they go, so are you like the COO? Every meeting we go to is like, well, what do you do? Even our directors of the different service lines are called supervisors. And so this is for information that I'm changing all of the titles to align with the CMH system and to prepare us for a county wage study they'd like to do next fiscal year. So if you're going to do a wage study, we have to have titles and positions that are apples to apples. Or we end up getting, well, I think this is kind of like this. So, and I'm also, even the state has asked us if we could do this because when they're trying to reach out for certain leads within CMH on certain things, they have to kind of get the translator list out of, oh, that's their coordinator is really the director, like somewhere else. And so doing the changes we want to do will allow that. And there's a comprehensive org chart, which we'll show you in a moment. Like you can go through and you'll see how all the position name changes. But just to give you some of the general kind of substantive changes, it would be changing my title from Executive Director to CEO. Muskegon CMH, he has both titles. He's CEO/Executive Director. But most every other CMH, this position is called the CEO. In the mental health code, it does say executive director, but then in the first sentence, you shall be the chief executive officer and administrative officer of the department. So that is why every other CMH has adopted CEO as the title of this position. Deputy director would be COO. Program supervisors would go to director, director of DD services, director of MI services, director of substance use services instead of supervisor. Our court and coordinators would become supervisor, and it kind of cascades down. This is all an attempt to do those above mentioned things of aligning to all of the CMHs, to prepare us for the wage study, and to really put us on par of how the state views us as a department. So this has been through HR. It's actually been through the union because some of these were union approved and they approved of the position title changes as well. It does not change the job descriptions of any of these positions. If there was a change in job description, then I would have to go through a very comprehensive process, including the title change for approval. It does not. It's simply the titles are changing. So within the HR world and stuff here in the county, they were okay with it. So feedback on that, don't want me to do it, want me to do it, be okay that I'm doing it.
I think it's great, but I think coming off your discussion about budgets, what's the potential impact between these changes? And that's where you go into the wage study.
Right.
Okay, so.
Yeah, it's just, it's the, it is that. So like when you create a C-suite, people think more expensive or like, that's different. And so usually in public government, they try to avoid that. And in some cases, you can't be a CEO if you have certain types of you have to have a different title. It's a Medicaid thing. This is not the case here. For me, it gives me more authority to go out there. It seems so simple, like, oh, the title change, does it really matter? I can be called unicorn, I don't care. But this actually just aligns us with everybody else in the state pretty significantly. And it is difficult when, you're saying you have a Medicaid deficit. You would think the issues are not linked, but in people's minds, they can be. Like, oh, now they're going to be the CEO. Like, wow, I wonder if that, caused the budget deficit, right? So I've sent this information out for staff of feedback. Supervisors will be meeting with people as well. And so far, we haven't had any negative feedback, like call what you want. But it actually is going to really help us in many regards, especially in the region, in the different groups that we're in.
Michael, there is one perhaps unanticipated expense item with this. We have to reprint business cards.
Yes.
And letterhead, but that's a nominal expense, and I support your proposal.
Yeah, and I will use my existing cards until they are expired before I order. Yeah, but yeah, now in the packet, there's also some organizational changes and you're not gonna, if you read through the whole thing, you're gonna be like, well, what were the changes? So I'm gonna summarize some of the organizational changes and then you can go back and you can kind of read our org chart. But I will have you pull up one aspect of it. And yes, I am keeping track of the time. So I don't know if you can make that bigger. Go to the one where it says, Michael, the next one. Yeah, that one. Yes. Okay. So one of the things that I wanted to emphasize is the change that's really happened in this position since I've been here last. And how, and it's been like this for a while now, so Lynn would have had the same diagram that's up here. But really, there's a lot more work than there used to be. And just this slide alone. I'm the chief contact with the state, obviously, for our general fund contract. I'm the main contact with the LRE, the regional entity. I also have a dotted line as a department head to all of the county departments. And then I deal with the whole org chart that follows below. So there is about 40% of my time that's really outside of CMH direct operations. Now, if you would have said 20 years ago, if that's the case, it wouldn't have been as much. But there's a lot more work that happens outside of James Street than inside in this position. Just keeping track of you as a board is, 100 hours a week. No. But the point is, I wanted to show this because it helps staff understand, too, why I might not be as present in the office. I do a good job letting people know when I'm out of the office. I have all kinds of methods. But, visualization and presence is important. So re-educating the staff, and they know this, but just to keep saying, well, the reason why I'm not here is because I'm in Muskegon all day and I'm over here for the next, because the level of complexity related to the Medicaid budgets and the management of it has grown at least 10 times since I've been here last in terms of the amount of regulations and monitoring we have to do. I mean, the state has just added a whole bunch of stuff. So that's one diagram we've never had in any representation of organizational charts. And it's more of a, I'm reporting to and some functions for there. Can you go back a page? The other substantive changes is right now I'm the direct supervisor of what I'm now calling the director of clinical programs, MIDD, substance use, and family services. I'm moving the direct supervision of those programs under the COO or the deputy. And I'm aligning myself with more of the centralized services that manage kind of like quality, compliance, contracts, rights, and access. I thought it would be important that I maintain direct supervision of the access department because it's the front door. And I want to make sure I'm really looking at that closely. And so that's a change for our staff where the direct supervision of some of our supervisors, now to be called directors, are going to move to the COO under my oversight. And I'm going to be really focusing on the centralized services of the operation because it's an area that I need to help reconstruct, get more familiar with, and put in more additional controls. This is not to say that who was managing it before didn't do a good job, but I need my emphasis to be there. In addition to knowing what's happening in all the different clinical programs. So I'm not moving away, but I'm changing that. And so Anna, under her role of COO, is going to take over some of those direct supervision of those programs, which I believe is one of the next slides. Keep going. Yep.
Dr. Brashears?
Yeah.
Can we get these graphics?
Yes, this should be in your, you'll get them. Yeah, we sent them to you in the email. You'll have them, right.
Thank you.
They also have names. I didn't put contact information on there. I know you want that. We'll get there, okay? It's like, oh, that's who I call for this one thing, right? So that's the real substantive changes of what I'm doing right now, is I'm taking the direct supervision of residential services under my direct supervision. I'm putting some of the direct supervision of our clinical programs under the COO as I take more of a role in the centralized services in the organization, compliance, contracts, working with fiscal, kind of integrating some of those things. Quality and compliance is a new position. If we have funding, I'll create. So I have positions that if there's available funding, we'd create administratively. One of them is Director of Quality Improvement and Compliance, because we have one compliance officer, plus some people that are helping, but really one. So when funding's available, we'll look at creating a director position under my control for integrating quality and compliance together. But obviously with the Medicaid deficit, I'm not filling that right now. The other thing we're doing is centralizing crisis services. So right now, each major division has their own way of dealing with crisis, or we have like a crisis department that deals with hospitalization. We have a kids mobile crisis, adult mobile crisis. I want to integrate them into one centralized crisis services department so the community has one-stop shopping in dealing with emergency response, crisis response, with people that are trained to deal with all populations. Because if not, I got to, okay, who's going out for the kids' crisis now? Do we have some, right? So we're centralizing that function, and when there's funding available, we'll create a director of crisis services so that the community will have an integrative way of how we're handling any type of psychiatric or behavioral crisis in our system. Right now, it's kind of in a lot of different places. Don't want to do that in the future. So what am I telling you? Name changes, me changing some of the direct supervision of what I'm doing versus the COO, integration of crisis, and creation of a quality and compliance director when funding's available, okay? And that's kind of like the proposed changes I'm making right now for titles and positions. Do they make sense logically? Any concerns?
Thinking that we have the, when we talked about the Nimbus feed, that fits in with the QI and your need, you want to make mention of that?
Yeah. So the state has us do a series of outcome indicators called the MIMBUS indicators, and it looks at like how quickly we serve people. Well, they're getting rid of all of those indicators, and they're about to give us over 3 years a total of 100 new indicators. So this position will help manage that. But really, it's the relationship between quality of care and excellence and compliance. Compliance is the floor, not the ceiling of excellence. So if not, we're always just trying to be compliant. To be excellent, you have to go beyond what's required. So merging those concepts together, having a unified methodology at looking at that, having staff that are trained in both quality and compliance to work with the departments in a centralized way. To me, it's how you get from having the floor of compliance to excellence. Right now, we're a compliant. We're not at the level of excellence we'd like to be at yet. You know, I think Chris asked me a long time ago when I was talking about this, but we're okay. We're meeting all the requirements. Absolutely. CMH is not out of compliance, but we want to strive to be excellent, even though we have a lot of excellent services already that we don't give ourselves credit for. So that merger is a way to start moving our strategic plan to center of excellence development and not just focusing on, we got through the audits, which I'll tell you, we have over 100 different audits a year. So, and we got like a handful of people trying to do it. So when funding is available, we'll create that position when it's available, but obviously I'm not going to add more positions. In fact, if we filled some positions, as you know, at the beginning of the year. Well, we didn't have our forecasting. So I'm putting a position freeze on unless the open position is vital for operations, like there's only one of them and you need to do it. So I have a checklist of how to determine which positions are vital that we can't keep frozen, but I am freezing all open positions immediately. We're not going to add. And that's kind of that presentation.
Questions?
I'm throwing a lot at you. I'm sorry.
No, that's good. A lot of really good information, a lot of structure, rebuilding, kind of restructuring. All right, so we are on to old business and Key to Happiness Counseling Contract with Dr. Michael Brashears.
Believe it or not, We are still working out the details. It will come to the board next month.
And this is in Coopersville?
Yeah.
Key to Happiness, okay.
Yeah,
And
a
you-
lot of the confusion is related to a misunderstanding of me and how the organization is structured. I finally understand it and now going through the due diligence to ensure that the contractor and the people providing the services meet all of our requirements and understand our treatment philosophy. And so that should be wrapped up for review by next, it usually doesn't take 3 months, people. So,
Question. This was originally brought to the board as a proposed contract.
correct.
It's my understanding, rather than dealing with this entity, you will be dealing with individual service providers in the same community to provide services in that community. Would it be appropriate for us to remove this as a tabled item and just dispatch it and have you bring whatever new contracts? forward?
Yeah. And some of the confusion is, as of last week, I've learned they've actually organized into a group practice. So the original contract would be good now because I didn't think they were organized as a group practice. I thought they were individual clinicians just using the space. I've come to learn that actually this particular organization has 1099 agreements with people. They're using the same EMR. The Keys to Happiness Administration are doing the billing. They're doing that stuff, which was information, Mr. Bird, that I was confused on. I thought it was separate individuals. So I'm just completing the due diligence to see indeed that I understand fully the organizational relationship. I actually had prepared to bring to you 2 distinct separate contracts today of individuals providing the service. But then I found out later in our process that indeed they're actually working similarly to a group practice. So I'm completing my due diligence. So believe it or not, the original contract could come back in its original form, but with a lot more clarification dealing with our concern on conflict of interest that we had and some other concerns we had with the contract that I believe will be remedied and you'd be able to look at and approve the contract.
So we can leave it tabled then?
Yeah, you can leave it. And I apologize both to the organization and to you. It normally doesn't take this long. I just did not have all of the facts correct.
We need you to take the time to do it right.
Yes, we have to ensure that, remember I told you, I should never give you a contract that you have to vote no on. So if I don't do my job, then you have to do your own due diligence in every single contract. So I have to complete that process in this one.
Right, so we'll table that item. And then next is the CMHOC Board Finance Subcommittee appointments.
Yeah, so we had no volunteers. My suggestion is we table this till January to let new commissioners come in, new board seats, whatever happens with our open seats happen, and then readdress it. Because I don't think we're going to have a subcommittee in December. So I'd like to table this until January.
Do that. Do we need to vote on tabling?
I think so.
Yeah.
I'll move that.
Support. For both items. So the motion is to table both Key to Happiness Counseling contracts and CMH Board Finance Subcommittee appointments. And do I have a motion?
Yes.
Support. All right, all those in favor say aye.
Aye.
Same sign. Moving on to new business. The
Yes.
LRE CMHOC contract.
Yes. So it's been several years since Ottawa County has had a brand-new contract with the Lakeshore Regional Entity. We've had nothing but amendments, extensions, all kinds of stuff through the years. We've completed the kind of discussions and negotiations with the Lakeshore Regional Entity about our contract with them. It's been through our legal department. I've done a review of it, and there are no substantive changes to the contract that note changes. In fact, the contract looks identical, in my opinion, to what we've been operating under. So in the LRE contract, it does not talk about the actual specific dollar amount that we get awarded, just so you know. So you're not approving a contract with a dollar amount. You're approving a contract that approves the methodology on how we determine how much Medicaid we get. And that methodology right now is that we get a payment per month per eligible Medicaid person per month based on the number of people enrolled in Medicaid in our county versus a different methodologies like who has the greatest need in their counties and move Medicaid that way. I've not been an advocate of the greatest need model because it just makes CMHs prove that their folks are sicker and sicker and sicker to get the amount of revenue they need. So I like an equitable approach that says every CMH gets the same amount per Medicaid eligible in their county to fund it. This contract continues that and continues the current structure that we have, that we've been operating under. And I know we sent it to you, and it's like, I think Tom read it, it's like this thick. And so what I'm seeking approval of, and our legal counsel has reviewed it, and there are no red flags that they see, is the approval to sign it. And then that way we can actually get our Medicaid disbursements next month.
So I'm going to go ahead and read through the motion and we'll
Yeah.
see if there's any discussion. So the suggested motion is to approve the LRE-CMHOC contract as presented that we were sent yesterday. Is there a motion?
So moved.
Support? Support. And any discussion from what Dr. Bashirs has shared with us? Seeing none, we'll go to a roll call. Well, there's no
There's no
dollar
dollar
amount,
amount.
so no. So all those in favor, please say aye. Opposed, same sign. Motion passes.
Hmm.
All right, next up is our favorite friend, Amy I don't know why. Amy B, and yeah,
Be a good-
Mast. All right, thank you, Amy B. Oh, I've had one of those last names before. That's really, my poor son has it, yeah.
Budget adjustment for our revenues. As Dr. Bashir said, we received notice of our revenues being reduced from what we had originally projected and planned for our budget. So we're just aligning that with our actual LRE projection on the 15th of November. We'll be working next with the expenditures. But we started with revenues because we wanted to be in a good place to be reporting expenses to revenue. Some of the adjustments that we're making in our process for projections will be much easier to do when we have our actual revenues aligned. So you'll see there's a reduction in our traditional Medicaid of 305,924, a reduction in our initial budget for capitated Medicaid of $3,295,000, an actual increase to autism services of $1,371,811. This is being covered by transitioning some of the money that we had budgeted in CCBHC. You'll see it kind of takes that balance of budget we had for revenue. So aligning that with projections for 25.
I'm trying to understand what the brackets and the minuses mean on the chart. Typically, a minus means a loss and a bracketed number means a loss. But taking the first line, for example, the revised budget minus 15,450,000, does that mean we're,
So within the general ledger, revenues are considered a debit to an account, so they are always recorded as a negative number. So all of the budget lines that have the negative before the number are just coming out of the general ledger as debits within that account.
but it's actual projected income?
Correct.
Okay,
Yeah,
great.
because expenses then are positive, so they are crediting back the account, reducing the revenue.
Not a sure.
Okay, but when we get to budget adjustment, a negative means it's a reduction. So for example, capitated Medicaid, instead of 15,295,000 income, we're projecting 12 million, so it's a reduction of 3 million. Okay,
So the
Right,
negative,
it's kind of confusing because you're using negative two different ways.
yeah.
You can look at that maybe to like the red to kind of indicate the debit and credit.
But red and
Yeah.
green probably might be
And I'm
better,
used to the
like red is
parenthesis
bad
model
and
as
green
well.
is
That's
good.
always a negative. Yeah.
I like that. Red
It
is
gets
bad.
pulled out of the,
Bad,
you know,
green
it
is
comes
good.
out of this, it comes out of our general ledger and then we just fill in where we're gonna add and subtract money. So it, we can adjust that. So it's easier to interpret.
Okay, I
Future,
haven't
but-
run the numbers here, but under budget adjustment, if we were to put a total at the bottom, we're saying the total budget is going to be reduced a couple $1 million.
Correct.
Okay.
2.5, right around.
Okay.
Mhm.
And does that mean if our expenses continue as they are this year, we may have a $7.5 million deficit next year?
If you have 31 admission. or-
It could mean,
classes.
I think that is where we're at. We are talking about having a deficit this year.
If all factors stayed the same.
Yeah.
Sure.
Yeah.
Mhm.
Does the state ever look at, historically, what the budgets have looked at or look like for each one of these, the CMHs or authorities?
state
And
will
then
look at
base
the-
the next year's budget off of that.
That would be logic. The state looks at general fund, but they really work with the PHPs or the Lakeshore Regional Entity as a way of managing those concerns on the Medicaid side. They're basically saying they base it based on region. They don't do it by specific CMHs,
Sure.
which is the rationale of having the regional entities in the first place.
Mhm.
So they said, look, we have 10 contracts for managing versus 46 being the CMHs. Back in the old days, we all had our own individual Medicaid contract with the state, and they would do that. And they would know a lot of individual differences within each CMH.
Mhm.
Now, that's all been put in the regional system. And so as far as the state's concerned, Lakeshore Regional Entity, we're just a provider on the Medicaid side.
Yeah.
So like, well, you figure it out. You have a methodology to figure the differences of each CMH region, and the state doesn't look at that for Medicaid. They used to, but now they do that at the regional level.
At the pain points here locally.
I know, but that's why
Yeah.
local advocacy will actually solve it.
Oh,
to remind-
No, yeah, no, I'm just thinking out because there is
Yeah.
that possibility if we're not looking at trends, right? At the state level, that, you're going to see maybe year over year deficits occur.
Yeah, and this is the precise thing that's happening in Kent County.
Here, yeah.
Yeah, Network
Yeah,
180 in Kent
right,
County, they're like, hello,
right.
we've done everything we can. We still have $19 million projected a deficit. So do you want us to provide the services or not?
Because we're mandated.
Right.
Yeah.
So you're correct. I just wish I could give you the answer that made sense. Like, yes, they do it at the regional level.
Yeah. No, and I don't
Unfortunately.
expect you to necessarily know the answer. It just seems logical
Yeah.
that they would look at it, so. Are there any more questions of Amy? Amy B?
I like it.
I do too. Yeah, I'm glad you like it. That's important. All right, well, thank you, Amy. And then next up is the November 2024 amended and renewed service contracts.
To vote on that, I think,
Information only is what I have here.
for the budget adjustment.
Shouldn't be.
Okay, so the motion is, all I have is the fiscal year 2024 LRE.
Oh, yeah, we didn't.
So budget adjustment,
Oh, there it is. BA1, yeah.
So we have to vote.
I'll move the approval of the BA1 budget.
BA1
adjustment.
budget, yeah,
I'll
budget adjustment.
support.
Thank you. We've had our discussion. All those in favor, actually, we'll do a roll call on this since it is a budget adjustment. Wonder where that's at.
I support. You moved it.
I did.
Sorry, Amanda. I honestly don't have that on my agenda. Okay. Okay.
Yes.
Yes. Yes.
Yes.
Yes.
Yes.
Okay,
Yeah.
that's what I have. Yes. Motion passes. All right, let me get myself adjusted here. The BA, yep, there we go. All right. And then next up is the fiscal year September LRE FSR attachment C with Amy B. Getting adjusted.
So this is just the document that our monthly financial status report at the regional level. This is where we first identified the deficit. At this point in time, which was November 12th, we were reporting a $5.6 million deficit. We have received additional year-end payments, so that's been reduced. We are still pending payments on today, the 22nd. We'll be posting payments, and we'll also have a cost reconciliation for our CCBHC dollars. That probably won't be reported for fiscal year 24 until after December. But this just kind of gives you the initial catch of where we ended up with all these expenses at the end of the year, and we were waiting on revenues and still showing a deficit that was higher than we had projected initially. So, and kind of where everybody is at the region as far as on that date. So,
Any further questions? Seeing none now, I can say thank you, Amy B. All right. Next up is the November 2024 amended and reviewed services contract is attachment D. The suggested motion is to approve and amend and renew November 2024 service contracts as presented. Do I have a motion?
So moved.
Support.
Now discussion with Dr. Michael Brashears.
So the first group of contracts, as you know, the way we're doing it now is renewals or amendment. Okay. So a couple of these kind of renewals is a service that we use through the University of Michigan to offer support for general practitioners in our community to get immediate consultation if they're prescribing psychiatric meds. So it's a way that we help community providers understand the different algorithms, treatment approaches with medications under consultation because they're not psychiatrists. So this is a very small grant that we have that allows us to have that service available. In the future, we'll be able to show you how much was utilized and what the impact was. But that's the intent of renewing this grant, is to really look at that. There is inadequate psychiatric services throughout the country, especially in the CMH service. So to have an organization at the University of Michigan to offer this service, and we can contract for it and make it available to our folks in the community is great. But I would like to see, and I've asked to see, so did it matter? Even if it's $5, did it matter? Did it help? What's the feedback? So I hope to provide an outcomes report on any of these grants specifically, but those specifically. And there was a lot of discussion. We were talking about grants in my Did You Know series last Friday about this. I think it was Sue that was asking me 100 questions. I don't know if she's here, but that's what those are. And then Kent County, hey, Network 180's on there. They have a training platform that we use to help complete our mandated training. There are over 17 trainings that most of our staff have to do, and they have a platform that we use as well for that. So that's how much it costs for us to do that. It's done electronically, and it's a very good platform, but the whole region's using it. So that's just kind of renewing that. And then we had to amend some contracts. A lot of it was rate increases for some of our providers. One was the clubhouse. There was a slight rate increase. Then there was Stuart Wilson that provides fiscal intermediary services for us. There was an increase in his rate as well. And then Pine Rest Christian Services we put on there to amend to include crisis services. We're in the process of discussing what we do with our Robert Brown Crisis Residential Program we have in Ottawa. Several of our partners are no longer going to use it, like Allegan, Network 180, or Muskegon. So there may be a chance we have to close it, or a Hope Network that does it. And so we need another crisis residential provider to help us deal with that. We use crisis residential programming to divert from hospitalization. So someone can go into if you're an adult, and primarily MI, if you go into a crisis, and you may not need the hospital, you can go into our crisis residential program for up to 14 days. And it has hospital-like but not identical services. It's a voluntary service. So this is a way for us to extend our contract out to Pine Rest that offers one of these programs as well, in anticipation that we may need another resource if the Robert Brown Center closes, which we're going to try to prevent, but that's why that's sitting there. So it's an amendment. And one of the things I'll ask the Finance Subcommittee or the full board in January is maybe giving me an authority over certain amounts for some of these renewals. Because sometimes the renewal amount's like $1,200 more, or it might be changing a code. And before, you wanted every change to come to the board. Most executive directors / CEO have like a $50,000 limit that they can approve a change in and then inform you of the change and not get approval of it. So in future meetings, I'll be talking about what my threshold could be, and you could say 0, or you could say whatever, to make some of these changes to existing contracts without them having to go through full board and county approval, but notification of the change. And as long as you see the impact on the budget, you should be okay. But we struggled with some of these because they're very small little changes. And it's like, all right, I could talk about, it's like $1,000 difference, or we're not sure yet on it. So for future discussion related to renewals and amendments, I'll entertain feedback on that of how we want to handle those, if it's a small change or we're just adding a code that they could use for billing to it. We've been, believe it or not, bringing that back here every time. So, but that's kind of a general description of what these are.
A reason why? I mean, is it like a low set that Robert Brown Crisis Center may be closing, or why we're not?
Well, in Network 180's case, they opened up their own comprehensive kind of like crisis intervention program. The other folks, it was utilization. They didn't utilize it as much. And what we'd have to do at Robert Brown is we have to actually pay for a bed if we use it or not.
Sure.
And they were just unwilling to do that. And we can't fund the whole thing ourselves. We don't have enough utilization to keep it full the whole time. And Hope Network legitimately said, well, for us to keep it open under this, we have to have the rates gonna have to go way up to account for open beds unless we shrink it.
Tap it, yeah.
So we're scrambling to figure out how to handle that level of care. It is the level of care, by the way, that's missing for IDD adults. So I wish we had a crisis residential program for folks with developmental and intellectual disabilities instead of going to the hospital. So it's something that we're trying to see if people would be willing to put together. You ask any of the residential providers, they know this all too well. If someone's in crisis and they can't stay in the home, it's either the hospital or have somebody keep an eye on them. There isn't that level of care. So we're kind of scrambling on that. It's a gap in the system.
Yeah. Further discussion? What's that?
No, I'm just thinking.
How could you use it?
Could I ask a question on the new contracts? Who's the grantor on the,
We'll get to those in a moment after you vote on this. one.
okay,
Yeah,
all right.
because that's the next set.
All right, so, let's see, forgive me, I'm on a different agenda now, so I'm trying to kind of catch up to where I was. We're at the amended and renewed service contract. So, the motion on the table is to approve and amend and renew the November 2024 service contracts as presented. We'll do a roll call vote.
Yes.
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 Yes. Yes.
Yes.
Yes. The motion passes. Moving on to November 2024 new service contracts, attachment E. Suggested motion is to approve the new November 2024 service contracts as presented. Do I have a motion?
Motion.
Support, and then we'll have discussion with Dr. Michael Brashears.
Yeah, so before you get to your specific question, just a couple of general observations. When you look at the new contracting list this time, you'll notice there are only 2 Medicaid contracts.
Mhm.
Okay? There are 2 grant contracts and 6 millage. Okay? When we're looking, because of our Medicaid position, when we're looking at Medicaid contracting, we'll be doing a close eye on that to say, is it an essential service or an essential need while we're in a deficit? I don't anticipate bringing to you new Medicaid contracts unless they're vital under this circumstance, because it would add to the deficit. So just note the sheer number of Medicaid contracts are 2 out of this list. Note that 6 of the contracts are millage, and all of these are the initial millage things we have budgeted to maintain key residential providers. This by no means the amount budgeted here given to them solves their rate problem or solves the funding issue. It's to keep them stable and afloat at the moment. And it's $1.6 million. So unless we get a way to get the Medicaid funding increased in the way we need, I mean, we need to make up that amount of money plus more to do that. But that's what those providers there. Now, I had a process where I sent out and requested who would need residential stabilization funding. These are the responses I got back. I reviewed them. They looked adequate. And it's not my intention, unless absolutely necessary, to use millage funding to stabilize residential settings. But we have to continue to do the best we can until we get the Medicaid revenue up to cover the true cost of care. So that's the big bulk of these. And then there's 2 grant ones, Innovate to Work, individual independent consultant. And that's to organize community stakeholders to identify, and it's a small amount, it's $2,400, to say other ways or other ways that we could work together in the community to extend our ability for folks to work. And then the other grant one is Revel Marketing. We have a contract with them to deal with our marketing needs for various programs that we have. And this is related to recruitment efforts for our licensed staff. We're having a hard time getting, when we have open positions, people to apply for them. It's working for CMH as therapists is a hard gig. You're not dealing with mild to moderate populations. You're dealing with severe and persistently mentally ill and complex needs all of the time. So this is to help with our marketing aspects of that as a department. Beth, I think you had a question.
Yeah, who's the grantor on those? Where does that grant come from?
That's a good question. Do you know the specific grant on for both of them? Who's
Yeah,
the
for
grantor?
We Innovate and the other one.
Yeah.
A substance use grant, I believe.
Okay.
Revel is the MDHHS recruitment.
We'll put in the future what the grantor is
Yeah.
and what that means. Michigan Department of Health and Human Services recruitment grant, yeah. But we'll add that to our ever-growing grid so that you know who it is, so you don't have to ask.
Thank you.
You shouldn't have to ask that, so we'll make sure it's there.
Any other questions? All right, seeing none. So the motion on the table is to approve the new November 2024 service contracts as presented. It'll be a roll call vote.
Yes.
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 Yes. All right, the motion passes. And next up is December 2024 CMHOC Board of Directors meeting with Dr. Michael Brashears.
Yeah.
Is to approve the rescheduling of the December 27th meeting to the Board of Directors meeting on December 20th, 2024.
Yeah. So do you want to move it to the 20th?
So move.
Support, yes. All those in favor, say aye.
Aye.
And opposed, same sign. The motion passes. So we don't have anything for general information, comments, or meetings attended, so we'll move on to public comment, our second round. Please come forward to the dais. You have 3 minutes to speak and introduce yourself and where you vote.
Peggy Juzinga, Harbor House Ministries, Jenison, Michigan. Just wanted to thank the board today for the approval of the millage funds. The impact is huge for us. To give you an idea, this year we have about a $1.3 million deficit where our costs compared to what the revenue is that we're bringing in. Next year, it's projected to be 1.7. The cost of care has continued to rise, and I understand the limitations of Medicaid, but fiscal realities are fiscal realities. As you guys are facing them, we are too. So I really appreciate the millage funds because it allows us to keep our doors open, and that's been tenuous in the last couple of years, and it continues to be something that we're, a question we never asked before. So I appreciate this is life-saving for Harbor House.
Thank you. We need solutions.
Hello, Krista Mason, Benjamin's Hope here in Holland. To reiterate what Peg just said, thank you so much for the millage fund approval. A couple comments that really caught my eye today's discussion. We can't cut services. Gretchen, I said, I think I heard you say we can't not deliver the services.
Right.
This funding is critically important. And in fact, when we applied for it, there was a different understanding of what the budget situation is. So I think we all might think, gosh, I wish I put a larger number in. But as Peg said, we're very, very grateful for this because this does allow us to continue to offer services.
Absolutely. Thank you to both of you for all you do. So, yeah, good morning still.
Good morning. I'm Dawn Nordike. I vote in Holland, and I am the executive director of Heritage Homes. So I have a few additional comments. I also very much reiterate what Krista and Peg have said. Thank you very much. The generosity is not only appreciated, it's vital for the continued services that we provide at Heritage Homes. And I think several other providers throughout the community. Heritage Homes has been providing services, and it was founded by a group of parents who were looking for a place to help their adult children with developmental disabilities move out of their family homes. They worked with county employees at that time in 1971 and with clergy to found Heritage Homes. So we've been providing services for 54 years. I've been fortunate enough to be part of that agency for almost 27 years. We provide the social recreation program. Thank you so much for the ongoing support. We've been providing that since 2017. Thank you for the renewed contract in 2015, or 2025 fiscal year. I hope that there's additional funding following that, or at least a different service model so that those vital services can continue throughout the service area and throughout the county through the various agencies that provide in addition to Heritage Homes. In addition, we provide services to specialized residential homes. We have 4 homes that are licensed, one that is not, that is a incredibly high service need home that kind of is above the specialized level of care. So that's an introduction to Heritage Homes. Very much thank you for all of the work and the support and the funding that you've provided. I also just want to take a moment, though, to emphasize not only was this funding vital to support what we're doing now. We're struggling to stay in business moving forward and to provide the highest level of care that we could possibly provide to the most vulnerable people in the county. When we talk about wages and what living wages are in Ottawa County, let alone what just Alice wages are, and I hope everybody's familiar with what Alice is compared to poverty. I want to just give a quick, and I know my time is going to run out. Heritage Homes is paying, going into the fiscal year, including the pass-through amount that the state is passing through, an average of 1921 now with the additional pass-through. We are still $5.05 below Alice for our average demographic employee, which is a single parent with one child. That's below average. That means people are working in poverty to serve the most vulnerable. We are $19.50 below living wages according to the current MIT standard for Ottawa County, Michigan, for one adult and one child. $19.50 below the wage needed to live in Ottawa County at a basic level. So when we start talking about, it seems like our wages are extremely high. They're not high enough to live. We are serving, or the people who are serving the most vulnerable people in our county are the second most vulnerable people in our county. So my ask is just to wholeheartedly support the request that Dr. Bashirs and the staff are making to the county to find additional ways to support the Medicaid deficit that we have so that we can continue to find innovative ways to fund the services to the people throughout our county. I think that's all I have to say, but I want to send a clear appreciation to the staff of the Community Mental Health of Ottawa County. You work tirelessly. You have many of you for decades. Welcome back, Dr. Bashirs. Thank you for hitting the ground running. Thank you, board, for the support that you've been providing and continuing to learn. Thank you very much.
Thank you. Very nice to meet you.
My name is Dave Barnowski, and it's no surprise I vote in Port Sheldon Township. I complain, I nitpick, but today, the vast majority of your meeting was just good government. Congratulations.
Thank you.
Rosalie Austin, City of Holland. I'm glad we can have these discussions civilly and that it is a budget crisis, but a reminder of the self-directed people have the same issues as the specialized residentials. And it boils down to the direct care workers are the backbone of, I guess, healthcare is a business, and we struggle finding people to do the work also. And they are undervalued, underpaid, and we couldn't do what we do without them. And Robert Brown, I miss him, but I'm sad that crisis residential, it's a necessary service too, but I would love to see it be an IDD, crisis residential, because that is a huge gap and lack of services there. And years ago, Heritage Homes used to have respite home. That was one-on-one, 24/7 care. There was 4 there, and they did an excellent job of meeting that need. And that would be valuable again, because there's some people that they need a short-term break, and they had that service available, and it was wonderful when it did exist, but it was costly. And yeah, thank you.
Thank you. Now, as somebody who provided emergency room care, I would say that's the worst place for people in crisis to be, honestly, in a small room for a long period of time.
Barbara Lee Van Horsen again, City of Grand Haven Momentum Center. I wanted to thank Dr. Brashears for the general education sessions that you've been having and strongly encourage you to move those outside of community mental health to really be in the community. And I'd like to offer the Momentum Center as a place in the Tri-Cities that you could come and host that conversation for the larger community. We're also in the process of beginning to plan a series of town halls on mental illness. So hopefully we'll have you and a large presence from CMH there to continue to help inform the community of the resources that are available, how to access them, and then identify those gaps that we can all work together to try to address. So thank you and happy Thanksgiving.
Thank you. Is there anyone else? Nope. Seeing none. Happy Thanksgiving to everyone. And thank you. This meeting